So, Dr. Stalin, are you speaking now? Oh yeah.
No, sir. I will introduce you, sir. I'll just introduce you and I'll hand over the session to you, sir.
Right.
Just
Oh,
yes, yes, sir. We are on live, sir, and we are starting the session, sir.
okay.
So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is UTI in women's health. I welcome all the participants. I request them to post their queries, if any, in the chat box so that we can have a short QA session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Gyan Ranjan Patnaik, sir. Sir has done his MBBS and MD OG. Sir is currently the consultant obstetrician and gynecologist at Mercy Hospital, Jamshedpur. So with this short introduction, I welcome you, sir. I'm handing session to you for your further proceedings, sir. Welcome, sir.
Yeah, thank you. Good evening, everyone. I'm sorry. First of all, I'm late because of some malfunction of my laptop, and I'm not a very computer savvy. So probably I need time to understand all this. Okay, but this COVID has taught us a lot of things going technical. And thank you very much. Thanks again, Shield, for giving me opportunity to speak on something which is very important and very common in day-to-day practice. So today's topic is UTI and women's health, which is very important. I am Dr. Gyan, practicing as a consultant gynecologist in a Mercy Hospital. So let's start with the introduction. Usually, what we understand with the UTI is an infection of any part of your urinary system, your kidneys, your ureter, or bladder, urethra, and most infections involve the lower urinary tract commonly, and mostly bladder and urethra. And as we all know, women are at greater risk of developing UTI than men. And among adult aged 50 to 20 years, it has been seen it is 54 more common than men. Incidence, it is the second most common infection following respiratory infections. 40% of all women will suffer at least one UTI episode in their lifetime. 1 in 5 of women between 20 to 25, 65 suffer one attack per year, and usually most this 30% of pregnant women, which is the most burden of us in practice because it causes a lot of complications. So they suffer from UTI in their antenatal period. So what are the risk factors? So risk factors could be iatrogenic drugs or behavioral or anatomic, or sometimes genetic. But iatrogenic, most common one is a Colles catheterization. Catheter provides an ascending route for perineal ascension of bacteria to enter the bladder. And mostly recent antibiotic use also another risk factor which causes change of vaginal flora, allowing uropathogen like E. coli to colonize, and spermicides, particularly spermicide jellies, they causes irritation and that allows attachment sites for E. coli. And behavioral issues like budding dysfunction, which is causing most a post-void urinary retention, which allows bacteria to grow. It gives more time, and frequent or recent sexual intercourse also is a risk factor for UTI. So that's why it is always advisable to avoid after intercourse. And anatomic, as you all know, the cyclouretary reflux, which causes urinary retention. So it's a good media for bacterial growth. And the retrograde flow also allows bacteria to ascend to the kidneys. And females, anatomic, because females have a shorter urethra, 4 millimeter compared to male, which is 25 centimeter, 4 centimeter compared to 25. So that causes easier for pathogen to colonize. And pregnancy also results in progesterone mediated smooth muscle relaxation of bladder, causing reflux, and compression of ureter also causes retention. Though these factors increases chances for UTI. And genetics, sometimes when familial tendency has been seen and susceptible epithelial cells are there which secrete less IgA, so causing less protection. So it is more prone for bacterial colonization. So what is the pathophysiology? If you see the pathophysiology, the etiology is most common is the E. coli, which is the enteric gram-negative Arabic bacteria. Almost 75 to 95% cases we we get the E. coli, and others are Klebsiella, Proteus, Pseudomonas. Gram positive, although less, but still there, like Staph, Saprophyticus, Enterococcus, and Streptococcus galacti. But in hospitalized patients, this E. coli volume has gone down to 50%, where the gram-negative species of Klebsiella, Proteus, Enterobacter, and Serraceae accounts for almost 40%, and gram-positive are rest for 10%. So the pathogenesis, if you understand, the first primary thing which happens is the colonization. The pathogen colonizes to periurethral area and ascends to the urethra up to towards the bladder. Once it reaches bladder, the ureapithelium, the fimbria allow bladder epithelial cell attachment and penetrates the bladder epithelium, and then starts following penetration, they start replicate and produce a biofilm. And after that, it starts ascension, which is once sufficient bacterial colonization happens, then it starts ascending towards kidney. So fimbria has a role in ascension process, and of course the bacterial toxins which causes reduced peristalsis, so which favors ascension. Similarly, once it reaches kidney, it causes inflammation, so pyelonephritis, causing a result of can causes pyelonephritis with a inflammatory response. And but this can also be done by hematogenous route, not only ascending, but common one is ascending one. And once it reaches the inflammatory cascade continues, the tubular destruction damage occurs. There will be interstitial edema leading to interstitial nephritis and acute kidney disease, acute kidney injury. Sorry. So how the patient is going to present you. Actually, a patient will present according to the parts involved. So once if it is a pyelonephritis, kidneys are involved, then you will have you will see the upper back and side flat pain and high fever with a chills and rigor, nausea, vomiting, and urinary symptoms will be less. But in bladder cystitis, if you see, you will feel more of pelvic pressure, lower abdominal discomfort. There'll be frequency, urgency, and dysuria, and sometimes hematuria. And if it's only restricted to urethritis, then it will be burning with urination, and that's sometimes discharge. So we need to segregate between complicated and uncomplicated UTI so that we can have a better management plan. So what is the uncomplicated UTI? It is usually considered to be cystitis or pyelonephritis that occur in a premenopausal adult woman. So it is a premenopausal adult woman with no structural or functional abnormality of pneumonia. So, and who are not pregnant and have no significant comorbidities like diabetes, chronic disease, or immunosuppression. So that could lead to more serious outcome if it is there. So uncomplicated UTI usually has a less serious outcome. Whereas complicated UTI can involve either sex at any age. A UTI is considered complicated if the patient is a child or is a pregnancy, or the patient has a following thing in person, any of the following, like structural or functional tract abnormality or obstruction or comorbidity that is risk like diabetes, chronic disease, as I said, and immunocompromise also. And recent instrumentation or urinary tract injury also can cause a complicated injury. So what could be the complications that can happen if you have a UTI, particularly recurrent infections, especially in women who experience 2 or more in 6 months or 4 or more in a year. And that could be a permanent kidney damage from an acute or chronic infection if untreated. And there is increased risk of pregnant women having a preterm labor and low birth weight. So, and at last, most serious is a sepsis, which is a potential life-threatening complication of an infection, especially if the infection works its way up to urinary tract through your kidneys. So now the diagnosis. For diagnosis, we need to diagnose three things. First, whether it's a UTI. Second, whether it's a upper or lower urinary tract. Third, whether it's a simple or complicated. So as we all know, the basic workup is the first urine test. Urine collection is a clean catch, midstream. Sometimes you do it with a catheterization to get a better outcome. And if a sexually transmitted STD is suspected, a urethral swab has to be tested before voiding. So, what are the options available? Either it's a dipstick or a microscopic. If it's a dipstick, yes, obviously it's tested rapidly, but some fallacies are there. So, like if you go for a nitrate positive, it is highly specific for UTI, but it has got a very low sensitivity. And whereas leukocyte esterase test, if you see, it's a very specific for presence of more than 10 WBC per microliter, and it is fairly sensitive also. And if you go for a microscopic examination, we can see it's a pyuria or a bacteria. Pyuria, if it is there, truly, usually pyuria happens when it is more than 10 WBC per microliter. But if it's a bacteriuria, sometimes without pyuria, also bacteriuria can happen, mostly due to contamination during sampling. And microscopic hematuria usually occurs, but gross hematuria is rarely seen. WBC cast, if it is there, so it's a sign of pyelonephritis or glomerulonephritis. And pyuria in absence of bacteria and UTI is possible. For example, patients having nephrolithiasis or a tumor or appendicitis or IBD also. So, what are the cultures? Cultures for when you do actually. The common examples where you include cultures is a pregnancy, first, postmenopausal, main or prepubertal children, patient with urinary tract abnormalities or recent instrumentation, there you need a culture. Patient with immunosuppression or significant comorbidities like chronic kidney disease or uh, um, uh, diabetes uncontrolled. Patient with symptoms are suggest of pyelonephritis or sepsis, that also need a culture. Patient with recurrent UTIs, that is more than equal to 3 in a year. Here you need cultures. So imaging, what are the things which are available for imaging? Urinary tract imaging choices include ultrasonography, CT, intravenous urography, occasionally voiding cystoscopy, and mostly it is done for children because children with UTI often require imaging. You need to rule out any anatomic or any structural abnormalities. So most adults do not require assessment unless it is patient has more than 2 episodes of pyelonephritis, not lower urinary tract. And infections are complicated. Nephrolithiasis, if you are suspecting, and if there is gross hematuria, painless gross hematuria, you have to go for imaging. And if fever persists even after treatment for more than 72 hours, so there you have to go for a imaging. So, what are the differential diagnosis? Differential diagnosis one is first of all, which is acute urethral syndrome, that is dysuria pyuria syndrome. You know, women complain of the syndrome with severe dysuria, frequency, urgency, and pyuria, but which thus resembles cystitis. But here, if you go for a culture, there will be culture negative. Whereas urethritis is possible cause because positive organisms like chlamydia and ureaplasma, which are not detected in urine routine culture also. And non-infectious causes like anatomic urethral stenosis, stricture, physiologic abnormalities like pelvic floor, muscle dysfunction can cause a frequency, urgency, those kind of symptoms. hormonal imbalances like ectopic urethritis. You may have a pain and dysuria in particularly in postmenopausal women. Localized trauma to the urinary tract, GI system, IBD, inflammation. Those cases may present like a UTI. So, what management you are going to do with it if you are suspecting a UTI? If it's a urethritis, sexually active patient with symptoms are usually treated presumptively for STD pending test results. So the best regimen, as we are all using subtraction single dose along with either azithromycin 1 gram or doxy 100 BID for 7 days. And if it's a cystitis, if you are suspecting cystitis, then 3-day course of either nitrofurantoin or cotramoxazole, the nitramethasone sulfamethoxazole is sufficient. But if you are using nitrofurantoin, be sure that a creatinine clearance is more than 60 ml per liter. And if it's an acute pyelonephritis, antibiotics are required. And if you are going for an OPD patient, oral antibiotic possible if all of the following are criteria satisfied. Like patient are expected to be adherent to the treating doctor, patients are immunocompetent, no nausea, vomiting, so that it will swallow the tablet and it will remain. And there is no volume depletion or septicemia. Signs of septicemia is cannot go for oral antibiotics. And patient have no factors suggesting complicated UTI. If it's a complicated UTI, there is no role of oral one. And if you are choosing oral one, better to go for a Cipro 500 for 7 days. And second option obviously is a cotramoxazole, but it is for 14 days. So some supportive therapy like cranberry concentrates, fluid intake increases fluid intake, and urinary alkalizer. These are all symptomatic relief. And, so in children, what we are going to do? If it's a children, then first line is a trimethoprim plain, 4 milligram per kg body weight. And if you are choosing cotramoxazole also, then it's a 4 plus 20 milligram accordingly. Cephalexin is a very good drug, 12.5 milligram per QID, maximum 500. Amoxiclav, and but you cannot use nitrofurantoin in children. It is contraindicated. Uh, Non-pregnant women consider empirical treatment with antibiotics for otherwise healthy women aged less than 65 presenting with severe more than 3 symptoms of UTI, then only use an antibiotic, otherwise no. Explore alternative diagnosis and definitely consider for vaginal examination for women with symptoms of vaginal leaks or discharge, whether it is there or not. Use dipstick test to guide treatment decision in otherwise healthy women under 65 years. And anyone who is more than 65 years, you have to go for antibiotic treatment. So, antibiotic treatment for lower urinary tract infection. Usually do not treat non-pregnant women of any age with asymptomatic bacteriuria with antibiotic. This is norm. Treat non-pregnant women of any age with symptoms and signs of acute lower urinary tract infection with a 3-dose course of nitrofurantoin or cotramoxazole. Particular care should be taken to prescribing nitrofurantoin in the elderly who may have an increased risk of toxicity if it's already the lung function is low. And take urine for culture to guide for change of antibiotic if it is needed, who do not respond to trimethoprim or nitrofurantoin. And in case of most important is in pregnant women because it is very common. So standard quantitative urine culture should be performed at the first visit itself. Repeat with the second urine culture once it is confirmed, and do not use dipstick test here. There is no role. Always go for a culture directly and treat here asymptomatic bacteriuria in pregnant women. Where in non-pregnant you don't need to treat. So with antibiotics. So what we are going to do? Treat symptomatic UTI in pregnant women with antibiotic. Take a single therapy for empiric. Always take a sample before start of any antibiotic. A 7-day course actually is sufficient for MOC saline and or cephalexin if you are, or augmentin if you are choosing. And given the risk of symptomatic bacteriuria in pregnancy, which may cause preterm labor and PPRN, so a urine culture should be performed 7 days after completion of therapy once again for the test of cure actually. So after antibiotic, what next? So we have different nutraceuticals nowadays has come up for an add-on therapy with the antibiotics. So there are several studies and papers and journals have presented with those molecules which has got a definite proof of uh, helping. It is helping a lot in many of the symptoms, and for particularly for recurrence, we have a lot of benefits out of this. So let's see what are those. First compound I want to discuss is the oxalic acid. So oxalic acid is a powerful anti-inflammatory agent which inhibits pro-inflammatory cytokines like chemocrosis factor alpha, prostaglandin E2, and its effects are almost comparable to the indomethacin, which is a very powerful NSAID, as we all know. And it's also a powerful antioxidant. It is anti-reactive oxygen species which prevents tissue damage and inflammation due to ROS. So oxalic acid is very helpful. There are several published articles published in different journals all over the world, and it has been seen that it is very much helpful, in particularly in anti-inflammatory effects. So these are the different articles which has been published, but I'm not going to in detail. Along with the cranberry extract, many of the studies. So second molecule which is important is a potassium magnesium citrate. Potassium magnesium citrate is it produces huge quantity of bicarbonates in urine. So once it is released bicarbonate, it neutralizes the acidification of urine in UTI. So that causes immense relief of burning maturation. So it is a very much dysuria, reliever of dysuria, you can say. So this is very important. And third thing, which is molecule nowadays is getting more popularity, is a D-mannose. D-mannose, what it is, it prevents bacterial adhesion, which is very important state, particularly for recurrent UTI. So D-mannose is similar in structure and binding site to uroplakin actually. So once it saturates the fimbrial H adhesions of the bacteria, it prevents bacteria from binding to urothelial glycoprotein, that is uroplakin. So if present in sufficient concentration in urine, it helps for not to, so it prevents bacteria to adhesion to the urothelium. So there will be less chance of recurrence. And second things, another molecule is a proanthocyanidin. Proanthocyanidin is similarly, it prevents binding of P fimbriae into the glycolipid receptor. So it is also anti-adhesion molecule. So it helps so that the bacteria will not get adherent to the urothelium, and it will flush out ultimately. So what are the measures we can do to just to prevent UTI? So as we all practice in day to day within our family, it's a generalized terms. I drink plenty of liquids, especially water, and cranberry juice. Obviously, it has got a very good property, particularly for cramps and all also. And the second thing is a habit of wiping. So it is always advisable to wipe from front to back, never be from back to front, so that perennial bacteria do not get access to your urethral area. So third thing is empty your bladder soon after intercourse, as we say, because it's a colonization the bacterial into the vaginal infiltrate, so it might ascend. So once you void, it will come out, it will flush out. So it is a healthy practice of empty your bladder soon after the intercourse. Avoid potentially irritating feminine products like spermicidal jellies. Change your bathroom also. So postcoital prophylaxis in women may be more effective if UTIs are temporarily related to intercourse. Usually, a single dose of one of the drug used in spontaneous prophylaxis is effective. Uh, Many times we can use it. And if it's a postmenopausal woman, antibiotic prophylaxis is similar to that of prescribed, but additional, we have to add topical estrogen therapy, which markedly reduces the incidence of recurrence because of vaginitis or urethritis. So, to summarizing the thing, what we discussed right now, it's a UTI is an infection of any part of your urinary system. Females are more prone to develop, and 40% of all women suffer at least one UTI episode in some point of their lifetime. The incidence of bacteria in pregnant women is slightly higher than non-pregnant women. Chances of progression to pyelonephritis is significantly higher, that is 40% in pregnancy, and high chances of pregnancy complications like preterm labor and uh, PPRA. So first line therapy always includes antibiotics. Nutraceutical definitely has a role. It provides relief from pain, burning sensation, and also flush out the bacteria. Uh, Thank you. I think mm, I didn't bore you much. My presentation is satisfactory. I hope.
So thank you, sir. Thank you for that another short and crisp presentation, sir, on this UTI. Let me wait for 1 or 2 minutes for the participants to post their queries, sir. If there is any queries, then I'll read it for you, sir.
Okay.
Sir, I personally have some questions. Like, sir, you are saying that antibiotic should be the first line treatment for this UTI, sir. So whether we should recommend these antibiotics for uncomplicated UTI also, sir, or what is your opinion, sir?
No, no. In uncomplicated, if it's a pregnancy one, once you're diagnosed, it's a case of bacteriuria is there in a pregnancy, particularly pregnancy. There you don't have any chance. You have to treat with antibiotic. Otherwise, uncomplicated UTI in non-pregnant women never required. Never.
Okay. Sir, when it comes to diagnosis, sir, for example, if a patient comes to you and you are diagnosing that it's UTI and you're asking the patient to go for some cultures and everything, sir. Meanwhile, what will be your treatment, sir? Uh,
Empirical. Empirical, you say.
yes,
You're
okay.
saying what is the empirical? Yeah, it depends on if somebody is having a symptomatic UTI coming to me and I'm test result is pending. So since being a doctor, you have to relieve her symptoms, right?
Okay, sir.
So
So,
yeah. Always we prefer a 3-day regimen like broad spectrum, either nitrofurantoin or mostly I prefer amoxicillin or augmentin or sometimes cephalexin because our domain is mostly to the pregnancy and women. So we prefer that pending reports, and along with we always add something add-on like what nutraceuticals we have described. So it gives actually it's a pleasant thing for the patient actually point of view. If you see somebody is getting relief within 24 hours or symptom, forget about the report. Shoot with first happy and then thank you.
yes. And sir, most of the times the E. coli is the culprit in this
Yeah,
UTI, sir.
yeah,
There are many studies which says that this Canberry extract is flushing out the UTI,
you're
that
right,
is
right,
the
right,
E. coli in the
right,
UTI tract, sir.
right.
So, well, is that your best idea to use this nutraceuticals like E. coli D-menos? That is what you
Yeah,
mentioned.
particular dominance.
Yeah,
Yes,
D-menos. So
yes.
whether it is advisable to use this drug for 1 or 2 days or 3 days maximum, then you can look out the culture and you can find out whether E. coli is persisting in the UTI, sir. Something like that.
Can be, can be. It depends on also the treatment what the patient is presenting to you. Right. So if somebody is coming to with a high fever and all the symptoms of pregnancy, more than 3 symptoms of UTI, sorry, pregnancy, I'm saying, more than 3 symptoms of UTI. So without starting anything and just adding nutraceuticals, may not be the ideal choice. Is for my practice says because I have to look for the patient point of view also. Yes,
Okay.
I may change after the culture report. Sometimes you may not get if it's a simple cystitis or a
Hmm.
urethritis, you may not get any report in also the culture. So there I will stop after 3 days. So, but I will
Oh,
continue the rest of the nutraceuticals what I have started.
yes. And sir, in case of recurrent UTIs,
Yeah, that is a yes.
what will be your suggestion? Yes.
Yeah. That is a
Okay.
point of concern where you are having a recurrent UTI, particularly E. coli, and then a diabetic or something as postnatally. There you have to continue for a longer time of this kind of drug with a D-mannose or cranberry extracts with this kind of products. It is very helpful. Instead of giving a very long antibiotic therapy, it doesn't give you much result. Once the course is over, you just keep continuing this for a longer time.
Yes. Sir, we have one question, sir. How to manage UTI in the first trimester of pregnancy, sir?
Here we are giving in first trimester even we are giving as an empirical therapy of amoxicillin most of the time we use, but many of the cases amoxi is resistant nowadays. So in that case also we go for either amoxi or cephalexin as a first drug. Nitrofurantoin is good drug as advisable also in all the guidelines are there. But the problem is in first trimester, most of the time the patient is having a lot of gastritis symptoms. So she is
Okay.
vomiting, she is having severe gastritis, and there if you add nitrofurantoin, it causes lot of more. GI side effects are very high. Actually, most of the women are intolerable during pregnancy to the nitrofurantoin particularly. But as guidelines say, you have to add and you have to go for a culture in the even in the normal pregnancy without any UTI. In first trimester, you are going for a culture in a routine.
Yes.
So yes, so you have to treat it.
Sir, I have one more question, sir. Like whether it is advisable to use these alkalizing agents like magnesium citrate, potassium citrate in this first trimester, sir.
Actually, it is not required as it is, like using the alkalizer with potassium, magnesium citrate, and all. But yes, this benefit you have to decide the practitioner's point of view. So uh, for my side, I'm using it actually. If I'm not wrong, I'm using it because for a short span of use of those products, I don't think it is wrong.
Uh, as you increase it, sir, like in this pregnancy first, they'll be having more and more this gastritis and from the
No, I didn't hear you. Hello, it is echoing actually.
now you're audible, sir?
No, it is echoing actually. Yeah,
Okay. Yeah, now you're audible, I guess.
yeah, no,
Yes.
yeah. Okay.
Yeah, yes, sir. Actually, what I was asking is like during this first trimester of pregnancy, there will be some gastric.
Hello, hello. Are you there?
Sorry, sir. There was some
Yeah,
internet issues
yeah,
with me.
yeah, yeah. Okay. Yeah.
Yes, sir.
Tell me what you
During
are.
this first trimester, like they'll be having this GI problems and all now, sir. Whether in
Hmm.
those patients, whether these antibiotics won't create any issues in those patients, sir. Uh, if they are having some pain during due to this UTI, in those
Hmm.
patients, what to be managed, sir? Whether paracetamol is enough, sir?
Paracetamol may not be the urea. The dysuria part may not solve it. I don't think so because the pain what you have as a dysuria, that burning pain, won't be relieved with a simple paracetamol. You have to add this thing.
We have in our product will be a very good gains and so so I think also it is going to be there.
I didn't hear you actually. There is a lot of echo with your voice.
Yes, sir. Sir, we are talking about this ursolic acid, sir. Ursolic acid, which is having a potent,
Yes,
yes, a
yes. It's a
painkiller,
very
which
good,
can
very
be
good, very good
a better
product.
option.
Right.
Yes, sir.
Yeah, that I'm
Yeah.
talking about. So those things I'm using it. So I
Yes.
don't have any restriction or I don't have any problem with using those drugs
Yes.
instead of using any painkiller or something like
Yes.
that in first semester at least.
Yes. Sir, thank you, sir. We don't have any questions in the chat box, sir. So
Okay.
if there is any questions, then we will be forwarding to you through mails and you can address those queries, sir.
Thank you.
So once again, thank you once again for being with us today and spending your valuable time with us today, sir. It was another wonderful, informative session, sir, and we are looking for many more webinars on such public awareness topics also, sir. Thank you very much, sir. I'd also like to thank my UACARE team for arranging such a wonderful webinar in this wonderful evening, sir. Thank you, sir. Thank you very much. And I will also thank my participants who have actively participated in this webinar, sir. Thank you, sir. Thank you very much, sir.
Thank you, Stalin sir. And Ranjan sir, thank you so much. Initially, there was some technical problem.
Yeah.
It was a wonderful session, sir, from your side.
Yeah.
And thank you once again. And in future also, as said by Stalin sir, we would like to conduct more webinars, sir. And what do you call real experiences since you have shared with us. We are expecting more such webinars, sir, and different topics also, sir.
Sure.
Thank you so much, sir.
Thank you.
Thank you, sir. Bye, sir. Bye.
Thank you.
Have a nice evening, sir.
Thank you.
Thank you, Stalin sir.